A 66-year-old self-identified Caucasian man, retired civil engineer, presents to the primary care physician for a routine annual preventive health maintenance visit. During the appointment, his wife reports that over the past year, the patient has been flailing his arms, punching the air, and shouting during the later half of the night. She notes that during a recent episode, he accidentally struck her while appearing to act out a vivid dream about defending himself. When awakened immediately after these behaviors, the patient is instantly alert, fully oriented, and able to recall the events or the details of the dream. He denies any daytime sleepiness, chronic snoring, nocturnal dyspnea, or changes in mood. So I think it's pretty important to note that he's having pretty vivid dreams where he seems to be acting out what's going on, and also ability to remember what's going on, but immediately coming out of the dream and being aware of what just happened is important to note as well. And furthermore, he has no past history of psychiatric illness and takes no medications. On physical exam, his mood, his temperature is 98.2, heart rate 72, respirates 14, blood pressure is 126/78. He's pleasant, cooperative, exhibits normal cognitive functioning. Detailed cranial nerve motor strength and sensory and cerebral coordination testing are completely normal. Symmetrical 2+ deep pen reflexes are normal. Muscle tone are present. Symmetrical 2+ deep pen reflexes and normal muscle tone are present throughout his upper and lower extremities. Resting tremors, shuffling gait, or postural instability are not observed. Which of the following conditions is the patient most at risk for developing in the future? So it seems like from just this simple presentation here of acting out dreams, sort of being able to vividly remember them, but also immediately be able to come out of them and have no issues or being fully oriented and alert, and also having a complete negative neuro exam. To me, this is a very classic presentation for REM sleep behavior disorder. And important things to note is that what's happening is during REM sleep, your body's supposed to go into the state of paralysis where you're not supposed to be able to move your muscles. And a patient with REM sleep behavior disorder is likely experiencing this loss of atonia during the REM sleep. And so they're able to move and act as if they're in the dream and it actually move their physical body. And they'll likely also be associated with really vivid dreams. And what they're doing is acting out the dreams in their sleep. And one of the important risk factors to remember about this is that it increases your risk for the group of alpha-synucleinopathies that are, specifically your Parkinson's, your Lewy body dementia, and some of the Parkinson plus disorders as well. But most commonly, you'll see on these exams Parkinson's disease being sort of the later manifestation of having REM sleep behavior disorder because of such a high risk of both of these being related. And so typically you see that Parkinson's develops about 1 to 2 years later. And so our answer choice here is that it's clearly going to be Parkinson's disease, but I can briefly talk about the other ones as well. So Alzheimer's is going to be more of your amyloid and your tau proteins being deposited. There's a little bit of cortical atrophy as well, and most commonly you see the short-term memory loss, and there's no correlation between this and REM sleep behavior disorder. Huntington's disease is going to be your autosomal dominant trinucleotide repeat disorder, so specifically the CAG repeat is what happens, and these patients will have these classic choreiform movements where they're not really coordinated. They might even have this thing called athetosis where their fingers are sort of just ringing along. Other than that, they might also experience a lot of psychiatric problems where they might experience a lot of depression, and so this change in mood where they otherwise didn't have any psych history is concerning. Furthermore, you could have a loss of executive function, so being able to do your activities and basic arithmetic and coordinate your schedule, things like that. Again, this doesn't have any relationship with REM sleep behavior disorder as well. And then progressive supranuclear palsy is one of these sort of rarely tested conditions where you classically see postural instability, lots of falls, and there's this classic vertical supranuclear gaze palsy that happens. And you can Google that to see what it looks like, but there's this sunset sign where there's a lid retraction, and you sort of see a little bit of, I guess, the eyes pointing upwards with the lid retraction. So you can Google that and see what that looks like, but it's one of these conditions that is also not related to REM sleep behavior disorder. It's more associated with tau proteins as well. And then vascular dementia is going to be classically seen with the risk factors for stroke, and there's going to be the stepwise decline. So each time the person suffers a stroke, whether ischemic or hemorrhagic, they have a functional loss, and their abilities are more focal neurological deficits, and over time there's a stepwise decline in their abilities. So for all those reasons, C would be the correct answer in this case.